There's lots of different steps to the treatment and management plans to patients with heart failure. Initially, it begins with medications, and our medications are very effective. Medications such as ACE inhibitors, angiotensin receptor blockers, as well as beta blockers actually have quite a bit of improvement and symptom relief in patients with heart failure. They can actually help the heart heal, and patients have quite a bit of improvement on these medications. The next step in terms of patients with heart failure comes in terms of their management of patients with heart failure are devices. And devices such as biventricular pacemakers and defibrillators, or ICDs, actually have also had a tremendous survival benefit in patients with heart failure.
The way implanted devices are used in heart failure refers mainly at this point to defibrillators and pacemakers that go into your chest, and then with wires that go into the heart. These are usually put in by electrophysiologists within our practice, and we've made it a clinical and a research focus to think about these things in a very intense way. Medicines are very important in heart failure. Beta blockers, ACE inhibitors, those kinds of things that have been studied over the decades and demonstrated to reduce mortality and morbidity. So they're very important. However, after those first 2 or 3 classes of medicines, there have been many, many other drugs that have been studied that have demonstrated no benefit. So medicines have done a lot, but now we're a little bit limited beyond that. So now come the devices. See what we can do using devices to try to improve patients' lives. And the 2 things that we really look at carefully are defibrillators, which can reduce the incidence of sudden cardiac death. So when patients have a weakened heart muscle or heart failure, they are at increased risk of arrhythmias, of fast rhythms that can actually make you pass out and may lead to death. These defibrillators keeps an eye on you and can bring you back if that occurs. The second aspect is what we call biventricular pacemaker, or CRT. And what this does is it doesn't actually shock you, but it actually paces your heart on a regular basis, every single beat hopefully, to try to synchronize the way your heart beats so that it's not beating out of tune like this, but actually beats together. And that can make a huge difference in how you feel. So these are 2 types of devices that may all reside in one can, but basically sort of separate treatments that we pay attention to and make sure that anybody who's appropriate for these things are at least offered and presented, and we can have a conversation about it. Heart failure has changed over the last 10, 20 years to the point where patients are older and sicker. They've survived the heart attacks, they have taken the medicines, they have used defibrillators and pacemakers, and yet they're still doing badly. They still have weakened heart muscle, they still can't walk across the room without getting short of breath. So what are our options?
In 2011, the gold standard for these patients with advanced heart failure is heart transplantation. And this is a therapy that's been around since the 1960s. However, over the last decade, we've had a plateau in the number of organs that have been available for transplantation in the country and actually in the world. With this plateau in the number of suitable organs, we've had an increasing number of patients with advanced heart failure. So we have a scenario of increasing demand, but level or decreasing supply. And I think in this scenario, the left ventricular assist device has really come to the forefront of a therapy used for patients with advanced heart failure.
There are new options potentially using assist devices. And what I mean by that is an artificial pump that a surgeon implants in your body to do the work of the heart. These have been around for decades, but only now, only recently have these devices become small enough and reliable enough to be a viable option for a vast majority of patients. So it's the size of a D-cell battery, the HeartMate 2 device that we're using, and it gets implanted under the left side of your chest and takes the blood from your heart, pumps it into the rest of your body, and does the work of the heart for you. So this is a big surgery with a huge change in lifestyle. So you can't just implant it in people too early because the doing reasonably well, and you don't want to trade that off for this major surgery. On the other hand, if you wait too long, then nothing will help that patient, including an assist device. So you got to find that sweet spot. And that's very difficult, and it requires experience and expertise. At this point, probably the sweet spot are patients with a very weak heart who have shortness of breath and extreme fatigue with minimal exertion, and may actually require a continuous infusion of a medicine to artificially help their heart pump a little stronger, so-called inotropes. So people who are on those medicines, who are stable with it and not getting worse, are probably the right spot.
In general, there's two types of patients that we implant these devices in. One are patients that we think are transplant candidates, that they have met the stringent criteria that they would be acceptable candidates for a heart transplantation. However, with transplantation, you have to wait around for an organ to become available. And that could be any length of time, from weeks to months to even longer than that. And so in that time, patients' clinical status can deteriorate and they can get worse. And they need something a little bit more immediate to stabilize them so they could effectively wait for their transplantation. And so this is a scenario we describe as bridge to transplant. And it's been a very effective way to keep people as healthy as they can while waiting the more definitive therapy for their heart failure, which is cardiac transplantation. The other indication for left ventricular assist device is what we call destination therapy. These are in patients that are not candidates for transplantation for one of many reasons. Often it's age, sometimes it's diabetes that's uncontrolled, obesity might be another one. And in these patients that aren't candidates for transplantation, they most likely have a life expectancy, when we think about advanced heart failure, of on average a year to two. And so we think with these devices, left ventricular assist devices, we can improve their survival over time, and not just their survival, but their quality of life. With our program here at the Christ Hospital, I think it fills an important need in the community that has previously not been here in Cincinnati. Patients have had to travel to different areas in the state as well as out of state to try to obtain this sort of life-saving and life-improving type of therapy. And I think it's an exciting opportunity for us here at the Christ Hospital to provide that to the patients of Cincinnati.